Hi, and welcome to everyone to our webinar today. Thanks for joining. We're going to be talking about the consequences of delayed care during COVID-19. This webinar is hosted by the Primary Care Collaborative, and I'm just going to give a quick overview of the PCC. It's a nonprofit multi-stakeholder organization that unifies and engages diverse stakeholders, promotes policies, shares best practices to support growth of high-performing primary care. It's a membership organization and has about 60 organizations committed to its mission, with a number of other supporters. The PCC is dedicated to advancing an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. Just a couple of housekeeping reminders. All lines are automatically muted. Please use your chat feature to type, or not the chat feature, there's a question feature to put in any questions that you have. The questions from the audience will be addressed after the panel discussion. So feel free to send in your questions at any time and we'll be addressing them after the panel discussion. This webinar is being recorded and the recording and slides will be posted within 24 hours. So I'm Diane Rittenhouse, and I'm a senior fellow at Mathematica and a family physician, and I'm happy to be hosting this webinar today for the PCC. In March and April of 2020, people across the United States stopped visiting their primary care doctors in person because of shelter-in-place orders and because primary care practices did not have access to PPE and adequate testing to protect their staff and their patients. A Commonwealth Fund study demonstrated that ambulatory care visits fell by 80% over a single week in March and continued to be depressed for weeks. I'm going to give a brief introduction to this topic, and then we're going to have a moderated discussion among the panelists, and then we'll go to question and answer. So why is this topic important? Because there's an immediate health impact when people stop showing up to the doctor. Not only were providers and staff getting sick and needing to quarantine, their patients stopped accessing care. Primary care practices were rapidly transitioning to telehealth using whatever technology was available to them. But we saw, as an example, childhood immunizations drop dramatically during this early period. By May, there was some data providing evidence of a rebound in ambulatory care visits and the suggestion that things were getting back to normal. But the Larry Green Center survey gave voice to primary care providers on the front line who were saying very clearly that things were not back to normal. Reports of patients having lost trust in the healthcare system, challenges with implementing and getting paid for telehealth, increasing mental health conditions among patients and providers triggered by the stress of the pandemic. People were not seeking help for heart attacks and strokes. They were postponing care for chronic conditions like diabetes and congestive heart failure. And reports from frontline providers described a decline in patients' physical health with increases in obesity and addiction. A very recent study from the Urban Institute reports data from a survey in September 2020 showing that 36% of non-elderly adults had delayed or gone without health care because of worry about exposure to the coronavirus or because a healthcare provider limited service because of the pandemic. This number was greater for Black adults compared to white and Hispanic Latinx adults. Adults with chronic conditions, especially those with mental health conditions, were more likely to have delayed or gone without care than those without chronic conditions. And finally, nearly 1 in 3 adults who delayed or went without care reported it negatively affected their health, their ability to work, or ability to perform other daily activities. Today, we have with us 3 very thoughtful healthcare leaders to discuss delayed care during the pandemic and the consequences for patients and providers alike. First, we're going to hear from Mark Toludo, who serves as Vice President of Strategy and Analytics for the Blue Cross Blue Shield Association. He's responsible for Blue Cross Blue Shield Association's strategy function, which includes the management of Blue Cross Blue Shield board-directed strategic assessments, market intelligence, and strategic consulting services. Additionally, he directs the implementation and ongoing operations of national programs that have direct impact on Blue Cross Blue Shield companies' channel strategies. including national retail partnerships. He also oversees the Health of America Report Series, which is a collaboration between the Blue Cross Blue Shield Association and Blue Health Intelligence that uses advanced analytics to report on key trends in healthcare to support improved quality and affordability for all Americans. He'll be sharing some slides with us and some data that he has, and then we're going to be hearing from Dina Baptiste, who is currently serving as epidemiologist and Director of Cancer Screening Guideline Development in the Department of Cancer Prevention and Early Detection at the American Cancer Society. With almost 20 years working in the public health sector, her current role is that of methodologist for the development of the American Cancer Society's cancer screening guidelines. She also supports the ACS Cancer Screening and Prevention and Control initiatives and serves as an adjunct professor at the Morehouse School of Medicine Public Health Program. Finally, we'll be hearing from Magdala Cherry. She's a board-certified internal medicine physician, a public speaker, and currently a Commonwealth Fund Fellow in Minority Health Policy at the Harvard School of Public Health. She is passionate about expanding the conversation on primary care and health in minority communities outside the exam room. She has interest in evaluating policy to address trauma-informed care for Black women and expanding the integration of mental health in primary care. Dr. Cherry is also the founder and chief operating officer of Not Just a Black Body. Through this campaign, she has been lending her voice and platform as a physician and as someone who has directly been impacted by COVID-19 to boldly address racism in the healthcare system and the impact COVID-19 has had on Black and Brown communities. Please remember that as the discussion goes along, you're welcome to enter your questions into the question area in the sidebar. And with that, I'm going to turn it over to Mark Toludo to present some early data.
Thank you, Diane. It's a pleasure being here and speaking on this important topic. And I'm delighted to be here with my esteemed panelists. So thank you very much. If you could go to the, go to the first slide, go to the next slide. At the Blue Cross Blue Shield Association, we represent a confederation of all of our Blue Cross and Blue Shield plans. We insure approximately 1 in 3 Americans, and that's a lot of interactions that our members have with the healthcare system and with providers and physicians. And we looked at these interactions over the past several years, specifically in 2020, to see how care is being impacted by COVID-19. And this data that I'm showing is through November. We will have updated data through December of 2020 in the next in about another month or so. But as you can see here, and was referenced, we saw a precipitous decline in obviously care. We saw a precipitous decline in preventative care in the first phase of the pandemic through starting in February, March, and April. And then we saw a significant, I would say a strong recovery between May and October. However, as it stands right now, through November of 2020, the utilization of preventative care is about 88% of the 2019 levels. Just a couple of points on some of this data. This data is based on claims of approximately 80 million of our commercially insured members. It doesn't include Medicare and Medicaid, and it's medical claims, both facility and professional services of our members. So, so the point here being, we saw a drop, we saw an increase subsequently through the spring and summer, but that increase in no way achieved a bounce back that was big enough to get us onto 2019 levels. The next slide, please. A little bit of a delay. There you go. All right, great. I think you went too far. Go back. Go back to one more. That's great. So when we look at this slide, we saw, if you look at this, there were substantial drops in all preventative care services particularly in cancer screenings and vaccines. But if you look at this, so we see the blue represents the average number of claims per 100 members in 2020, and the gray is the average number of claims per 100 members in 2019. As you can see, we saw a drop in a significant drop in wellness visits, a significant drop in vaccines, a significant drop across cancer screenings, lipid panels, and all the way down to other types of screenings. Of particular concerns are the drops in cancer screenings and vaccines, given obviously the downstream impacts that those have on our healthcare system. This is what we're seeing in our data thus far. And if we turn to the next slide, I want to focus a little bit more in the next several slides on cancer screenings and vaccines. So if you turn to the next slide, you could see from our data, again, this is commercially insured. These are our commercially insured members. We see that cancer, among cancer screenings here, breast cancer and colorectal cancer screenings had the largest utilization decline through November of 2020 compared to the period in 2019. We're also seeing declines in other types of cancer screenings, cervical cancer, prostate cancer, not to the degree of obviously breast cancer and colorectal cancer screening and cervical cancer screenings, but we are seeing a drop in those screening rates. And this is, our data reflects data that has been recently published by other sources as well. The next slide. This should get at vaccines. So we've been looking at the impact of vaccines. If you turn to the next slide. There you go. If we look at the impact of vaccines, we've been studying this, and our vaccine rates, when we looked at the DTaP vaccination, the measles, mumps, and rubella vaccination, as well as the polio vaccine, we are seeing those rates decline, as you say, by 26, 26, and 16% respectively. So we're seeing declines in these vaccination rates as well. And we estimate, if you turn to the next slide, we estimated in September that if the trends continued, about 9 million DTaP, MMR, and polio vaccines could be missed by children aged 1 year to 10 years of age in 2020. It looks like that 9 million, that was our estimate in September. We think that 9 million will be somewhere in the range of 7 to 8 million, but it's still a very significant number. So that's why obviously we're concerned with not only screenings, but missed vaccinations and what that, and the downstream impact of that on overall public health, as well as our healthcare system. And then finally, the last slide really reinforces what I just said earlier. We're seeing declines. We're seeing declines in all of these current. If the declines continued, we estimated 9, it'll probably be around 7 to 8. And these decreased vaccination rates put all of our communities at higher risk for measles, whooping cough outbreaks, and can threaten current community protections against polio. And some of this has been supported through other means as well, and through other articles. But we continue to monitor through our data the impact of delayed, deferred primary care, and the impact predominantly given the scale and scope of screenings to the population, as well as vaccinations. And that's our latest data. So I'll end there, gives you an overview of what we're seeing, and really validating a lot of the discussions that have taken place. And I'll turn it over to my panelist, Deanna, to build off of that. Deanna, the floor is yours.
Thank you, Mark. And as Mark just mentioned, the drastic shifts that we've seen in cancer screening. So shortly after the COVID-19 pandemic was declared.
Maybe the
Sorry. Oh, is everyone on mute? Yeah, so shortly after the COVID-19 pandemic was declared and we all had to shelter in place, you may recall that the CDC recommended that healthcare systems prioritize, and of course, it was reasonable at the time, urgent and care visits and delay elective care. And of course, following suit, the American Cancer Society and other specialty organizations came to the conclusion from receiving, especially for us here at the American Cancer Society, after receiving many calls from patients and stakeholders, we recommended that no one should go to a healthcare facility for routine cancer screening until further notification. So those also contributed, of course, we were in the middle of a pandemic, to some of the drastic shifts we saw. Next slide. So this shift in healthcare resulted in a drastic change, of course, as Mark showed some data, in the uptake of cancer screening and cancer care. This data, of course, this particular slide, these are modeled estimates, but one of the earliest reports that came out in the spring of 2020, a few weeks, a couple months after the pandemic got started, included the effects of the pandemic on preventive care. And that report came out from the IQVIA Institute, and they looked at patient care data for over 2 million patients, medical claims data for over 2 million patients, and included some information on the shifts that we were seeing in preventive care, including cancer screening. Well, these are just, this particular slide represents some modeling estimates that they did based on that data assessment. And with none, they estimated that with non-essential appointments and screenings canceled or postponed for these 5 diagnostic test procedures for common cancers, the disruption resulted in about 22 million patients, or 22 million screening tests not being performed in that short period of time. I think their assessment was for over a 3-month period ending up to June of 2020. Also, they estimated that over 80,000 positive cancer diagnoses could have been missed or delayed during this period of time. And so this is very concerning for us, because we all know that having a misdiagnosis could potentially result in a cancer being diagnosed at a much later stage. And that I'll talk about in the next slide. So this is from another presentation of early data that came out in the spring of 2020, shortly after the pandemic began. And this is a cross-sectional study using just ICD-9 codes for cancer diagnosis for patients submitted to a national testing lab. And they primarily looked at the mean weekly count of newly identified cancers in the weeks immediately following the shelter-in-place order, and compared that to baseline, which they defined as the same period from 2019 and up to February of 2020. But the takeaway from their data, or their cross-sectional review, is that overall the weekly diagnosis fell by about 46% for all 6 cancers. That's across the board. But for breast and colorectal cancer, they had a just over 50% decline in diagnosis. Now, this is very concerning, because we have no reason to believe that something drastic happened to cancer development to result in this big shift in numbers, other than the reality of patients just not showing up, and therefore we have a delay in diagnosis, and that's very concerning. Next slide. And this is very concerning, of course, because of the downstream effect that this could potentially have. And of course, this again is modeling estimates of another report that dealt with the effects of these delays in screening and diagnosis of what we could potentially expect in the future. And if over the next 10 years, the estimate is for about 5,500 excess breast cancer deaths and about 4,500 excess deaths from colorectal cancer by 2030. And of course, these numbers are very troubling, though we should remember they're modeling estimates. And also, I think the projection that they used was for a 6-month delay or disruption in service. So we're hopeful that this is just worst case scenario. And as we move forward and try to do a course correction, that this will not be the case. Next slide. Oh, I'm done. I think that's all I have.
Wonderful. So just to remember that you can enter your questions in the question panel at any time. And now we're going to open it up for just a conversation among the panelists, and we'll save some time at the end for questions from the audience. Magdala, I'd like to turn to you, having just listened to all of this data on cancer screening and cancer diagnoses being postponed, and services just not being rendered over the time of COVID-19. What concerns you the most about some of this data? What strikes you as being the most concerning?
I think, so first of all, thank you for having me. This is a great discussion, and I'm happy to be with all these wonderful panelists. To be honest, as those numbers were coming up, what automatically happened for me was the parallel of what was happening in our country, and those well-known individuals that we saw die of cancer and how that could have played a part. So for example, we know John Lewis passed away from his struggles with pancreatic cancer in July. We had Chadwick Boseman, who passed away from colon cancer in August. And then September, we lost one of our Chief Justices, Ruth Ginsburg, right? So why I think that's necessary is when people think about health, and in my experience as a primary care doctor, people think of it as what's going to kill me and what's in my face right now. So obviously the pandemic was in everybody's face right now, right? And being fearful of catching the virus and dying from the virus. And a lot of times that puts a lot of these other things that you can't see happening in your body on the back outskirts, because you're really prioritizing just staying alive. And right now staying alive looks like fighting a virus and making sure you don't catch a virus. And then two, some people may assume that, okay, you hear someone else in your family or a relative or someone in your social network has cancer, that you're going to go run to the doctor and get screened. I've seen the opposite happen a lot of times in practice, where hearing an individual get diagnosed with cancer and die from cancer actually scares you because you don't want to find out the unknown, because you're also afraid of dying. So I also wonder how much of seeing these deaths happen, both from COVID, but also seeing so many people who have died around us, people that we saw on the TV screen die of cancer, also scare people into not having that conversation. So not having access to your primary care doctor where you can keep having that conversation to kind of help dispel any myths, any fears, having a dialogue also hurts in being able to get people screened. I think that's the part that we lose in the conversation about primary care. It's not just checking off a box and saying, hey, I gave you a slip for your mammogram. It's also the dialogue that we're able to have with our patients on, why are you scared about getting a mammogram? We talked about this last month and you didn't get it done. What am I missing here? Oh, you had a family member who died. Okay, so can we talk about this more? Or you saw someone go through a really traumatic experience as they were getting treated for cancer. To not go to your doctor means not only don't you get likelihood of you getting screened decreases, but it means the likelihood of you having these intimate, personal conversations also don't happen. And that's also going to play a part into the way we see that translating in the statistics.
Thank you. Thanks for that. What about, Mark, have you seen, we've talked about the mental health crisis being sort of characterized as the second epidemic that's kind of following behind this COVID pandemic. Do you have any data that speaks to the rise in depression or anxiety or substance abuse over the past year?
Can't hear you.
Can
I
hear
know,
you.
after After a year of doing calls all the time, I can never get that mute button fixed. So, but I'm learning after a year. So great question, Diane. I really appreciate it. Yes, we are seeing, obviously everybody's talking about the impact of COVID-19 on mental health and behavioral health. And, you know, we've looked at not only our data over the last 5 years pre-COVID, but we're looking at our data post-COVID, and we did some surveys. So let me just walk you through a little bit of what we're seeing in some of our data pre-COVID, which was alarming to a certain extent. Pre-COVID, when we look at our membership, our commercially insured members, anxiety overall for our members, our commercially insured members, has risen over the past 5 years by 18%. The prevalence rate per thousand has risen over 18%. Now, some of this can be due to our diagnosis effect. We're better at diagnosing anxiety, just like major depression, as well as substance use disorder. But some of it, as we learned through our in-depth work with millennials a couple of years ago, there's clearly something going on with you know, our lifestyle, the pressures that we face in terms of what's causing anxiety to increase. When we look at anxiety overall, it increased 18%. It really significantly increased among Gen Zs as well as millennials. Gen Zs have, you know, an increase in prevalence over the past 5 years of 38%, and for millennials, 21%. When we look at major depression overall, diagnosis rates, prevalence rates for depression across our members increased 33% over the past 5 years. For Generation Z, around 65%. For millennials, somewhere around 40 to 45%. And then we look at substance use disorder. For our overall population, that increased by 22%. And most notably with the millennials, that increase is over 17%. So clearly, this is data pre-COVID. We're looking now at post-COVID, and we'll have updated increases in prevalence rates in anxiety, major depression, and substance use disorder. But we're very concerned and very alarmed that obviously these increases will only continue to get higher and become more prevalent. Finally, to this last point, we did a survey. We did a consumer survey in the fourth quarter of 2020, and we found that from our consumer survey, along probably with others who've done similar types of surveys, 84% of Americans Americans who we surveyed, adults, indicated that COVID-19 had a negative impact on their mental health. And those negative behaviors have risen since the pandemic. We've seen a slew of negative behaviors rise since the pandemic. There's a 23% rise in alcohol consumption, smoking, vaping, and drug use. So we're seeing the rise in some of these, I would say, risky behaviors or behaviors that lead to worsening health outlook, especially it relates to behavioral. So clearly, the pandemic is having an impact. The quantification of that impact will be fully known as we finalize our as we continue to look at the impact across 2020 and beyond, quite frankly, into 2021 and 2022 as well, because it is a long-term problem and a long-term issue that we're concerned about. Thanks, Diane.
If I can come off of the comments that Mark present, I think it's also to highlight that fact that mental health is taboo in some communities, which is why as a woman of color, as a Black woman in medicine, this is where having this dialogue in person, not even on a phone or even telehealth, but to be able to come to the office and talk to me about this has significance and has a lot of power. Because a lot of times when I'm seeing a Black patient or seeing a brown patient, they don't want to talk about it, right? And they don't actually give it a name. They don't call it anxiety. They don't call it depression. They call it it's part of life. So I will also challenge that even the numbers we do see, they probably will not highlight the extensiveness of mental health and the impact that it's having in our communities. And if we're going to have this discussion, we cannot have it in isolation to just COVID-19. We have to talk about the racial reckoning that happened in our country and how that experience of what's happening in your community, how that actually has a large systemic effect on our bodies, and how experiencing things that impact your community translates to impact your health. Again, won't always be captured by data, which is why sometimes I say, let's not always find comfort in numbers. Let's also dig into the numbers that we are not capturing, because it's not actually going to be seen by all groups. We don't know if we're asking it the right way, if some of our ways of screening actually take people out of the equation. And if you think about the impact of mental health, depression, and anxiety, it's one of the biggest causes of disability in our country. So it actually stops us from being functional. If you're not functional, if you're not being able to care for yourself, the last thing you're going to do is go and get your cancer screening. The last thing you're going to do is go get your colonoscopy and your mammogram if you're literally just fighting to wake up and find value in your life, and wake up and find value in continuing, and then not having a person who's your advocate as your doctor as someone you can easily access.
I was thinking about that as Mark was talking about some negative behaviors. I was thinking, well, another way of framing that would be coping mechanisms, right? With some of the trauma that we've all experienced over the past year. And so I think some of the sedentary lifestyle, the increase in obesity, the increased alcohol consumption, and you were saying nicotine and vaping and addiction, all being part of the complexity of the problem.
Mm-hmm.
Agreed. That's a great way to put it.
And I would also say, great point too. We're seeing, obviously, when we look at our data, I know data only gives you half the story, but when we do look at it, we do notice an underdiagnosis that's happening in the Black and the brown communities as well, across a lot of these behavioral health conditions. So.
Yeah, because a lot of it too, in this conversation, right, about delayed care, a lot of it is cultural, but a lot of it is primary care is a sense of having multiple conversations. There are even when we talk about your common diagnosis of hypertension, there are a lot of patients who are like, no, doctor, I don't want to take a medication. And it's actually multiple visits, multiple conversations that allow them to build trust, to see what you're trying to say, get an understanding of its impact if they don't take medication. So a lot of times it's not your first visit that they actually take it. It's your third, your fourth visit that they actually take your medication, right? So when we have this conversation on delayed care in primary care, it's significant because a lot of times it's taking longer to get into your visits. The visits are not in person sometimes, right? And yes, it's nice to be able to still have access to your doctor via technology, but not everybody has that access. And it's still not the same. I've done some televisits myself, and sometimes you just want to be in the office. You want to flash a smile with the person at the front desk. You want to feel like you're back in that zone where you're used to seeing your doctor, and you're minimized. You're not getting that chance. And the other part too is I have a lot of colleagues that got pulled into the hospitals. So even though they were working in outpatient, they've been helping with the overload and influx of patients coming in with COVID in the hospital, which means that typically the people that would see them on the outpatient side for their primary care are not seeing the same person. They're seeing another practitioner, another doctor, an NP, a PA, which is great that someone can stand in the gap, but then you lose that trust and that communication and that bond that doctor was able to build, which is why delayed care is so impactful in this conversation.
What do you think it's going to take to catch up? I just, when I think about this, I think, well, some care, there may be some acute care that kind of resolves itself, and that was an opportunity to see somebody to sort of continue to build that trusted relationship in primary care, but maybe they had a condition that will take care of itself and go away and not be a big deal. But there's so many other conditions that we're talking about here, acute, chronic, that if they're not taken care of, they're just going to worsen over time, and we are going to see this delayed impact on mortality, morbidity, hospitalizations, et cetera. What do people think are some strategies that we can actually get caught up? How are we going to get caught up on all these childhood immunizations, for example, and all this cancer screening?
Well, again, thank you for including the American Cancer Society in this talk. And we started back in July when a lot of the country and facilities started opening to figure out what we can do to address this issue. And one of the resources that we tapped into was the our National Colorectal Cancer Roundtable that the American Cancer Society is a part of and co-sponsors. And so we started there in terms of improving or pushing our initiative for getting back to cancer screening. So that was our first step. And we work with the roundtable. They have a partnership throughout the United States and in all 50 states. Many primary care affiliates on the roundtable to develop guidance to reinitiate colorectal cancer screening. Later on in the summer, in August, and through October, we expanded that initiative to return to screening initiative across the board to include for cervical cancer, breast cancer, and we develop a guide that we distribute to many of our stakeholders, and it's available online as a resource from the American Cancer Society that our partners can use, or anyone who were at that time, or if still now, having challenges in the primary care setting or in the specialty care setting with re-engaging in cancer screening. More recently, in the last quarter of 2020, we saw there was a need to re-engage the public, because let's face it, because you open the door, people are just not going to show up. So we did a survey, and we collaborated with many. A matter of fact, it was initiated through a collaboration with other organizations such as the CDC and the National Comprehensive Cancer Network. And individuals came together to develop a comprehensive messaging for public outreach. And now we have tailored messaging that can be used. There's a social media campaign that's going on, and that now has expanded into a national consortium that includes about 29 organizations that are dedicated to cancer prevention and cancer care, and screening in particular. And that initiative is going on, and as time goes, hopefully in the next year or so, we're hoping that we will see some positive effects coming out of that by so many organizations recognizing that this delay that we had in care is an issue, and if we don't get proactive and take drastic measures, that it's going to, could potentially be, not to be overly dramatic, another pandemic downstream. Now, one of the issue, and Magdala touched on that is the cornerstone of this initiative as from the cancer screening perspective. We've always had recognized that there are disparities in cancer screening, and COVID will likely make this worse. That's unfortunate. There are notable distinctions between those individuals who are up to date with cancer screening and those who remain on screen or are not adherent to screening. And we have a group at the American Society that is dedicated to equity in cancer care, including screening. And so not only do we have research going on to look at ways that we can address this disparity and hopefully remove some of the obstacles that may exist to cancer screening, we are making it the cornerstone of this return to screening initiative by measuring our success by how much we're able to shift the needle on the disparity that exists in cancer screening.
Wonderful. Yeah, it almost seems like we'll need a national campaign to go back to your doctor, go back and check in, go back. And we had a question that was submitted before the webinar from one of the participants asking, is there some checklists that I can go in to my doctor with and make sure that I get the full body. No, I don't want to say scan. I don't mean scan, but you know, sort of the full do-over, because I've missed out in the last year on COVID-19, and I want to make sure that I'm healthy. And unfortunately, I'm not sure that we have exactly that, but it does seem like we need a national campaign to get the public back in to see their primary care physician and reconnect and catch up on some of these issues that are so important, especially children, Do you think
I
we've
think we
lost
have a
the
good
trust of the public?
opportunity.
Go ahead.
Yeah, I think we have a good opportunity to have that now too, if we can think of ways to get people thinking about this. A lot more people, because of how the pandemic played out, have gotten more invested into like looking things up themselves. Some of it, you know, a little too conspiracy theory-ish, but people have gotten used to some degree looking up information, asking for more information. And in some circles, talking about health topics were a little bit taboo, and almost left to the doctor to deliver it for you. So in a way, I think I think this is actually hopeful. As a doctor, I'm kind of hopeful that now that so many people are engaging about their health, especially when people have been thinking about, do I want the vaccine? Is it good for me? Does it fit for me? I think we should actually celebrate this engagement and actually validate a lot of people who, you know, what we keep calling vaccine hesitancy, which is really just questioning and asking more questions. We should actually celebrate that, celebrate more people getting energized, asking questions, saying, hey, I have concerns, and use that same energy to get people to ask more questions about breast cancer screenings, about other vaccines, about colon cancer screenings, and use this momentum in a time like now to build trust. To the question that you're starting to pose, is to build trust, and as we see more people willingly wanting to have more deeper conversations about their health and what decisions are in front of them and why it's important to think about one decision or one treatment option over another. I'm optimistic about that. I don't know if we're doing that very well, because I do think some of the language that has been used in the media about how people ask questions, especially in regards to the vaccine, has been isolating communities, especially when they think about hesitancy. I really hope we can change the dialogue. It's good. This is good. Just like you ask questions about the vaccine, ask me questions about the mammogram. Just like you ask me questions about the vaccine, ask me questions about why I want you to go get a colonoscopy, why I need you to actually get ideally would love for you to get a full colonoscopy, because here's what I'm looking for. I've seen a lot of my colleagues doing more explaining, more engaging, more breaking down the elements for their patients and their constituents and their community, that I hope continues even beyond COVID. That we start actually not just throwing information at them, but actually engaging in more dialogue, addressing concerns, addressing fears, so we can actually help better health outcomes.
So true. Go ahead.
One of the, I don't know if it's, don't want to use the word good thing that came out of this, but we've actually, we've been advocating for this for some time, and we've been getting some anecdotal reports that this is happening, where some patients and even healthcare providers said the use of telehealth had allowed them more time to talk to their patients. And I found that to be very interesting, where they're able to, because you have an allotted amount of time that's booked telehealth. So spending 30 minutes talking to that patient during their appointment, they were able to have more meaningful conversations. And one of the things that we've been struggling with for primary care providers to do is for cancer screening and cancer care is to do risk assessments with their patient. Because even now, especially with the backlog that we have or had in screening, and patients are maybe still a bit reluctant to engage, identifying those patients who are at high risk, partly through having those meaningful conversations, talking about family history, talking about symptoms that they may have, that they may not know, that are related to possible development of cancer, colorectal cancer. I know a lot of the symptoms for that usually go not unnoticed, but ignored by patients, and that's very troubling. But just by talking to your primary care doctor, having a more meaningful conversation, and not just checking out. Someone ask about just checking everything off. That would be my suggestion. Would just to schedule that good old-fashioned annual checkup. And have a conversation with your doctor. If you're still scared about going in, if you have access to telehealth, then take that opportunity to find out when have your doctor tell your doctor, I'm still a bit nervous to come in. I know I need a checkup. And that's an opportunity to have a conversation. And what I want to say is that communication with patients, nervousness, that nervous energy about going into a healthcare facility, unfortunately, still does exist in many communities because they're afraid that that's where they're going to go and get COVID. And so we have a lot of communication to do to engage patients, make them feel relaxed.
Someone had a great question in the chat about building trust. I'm like looking at the chat box. I think one way that I've also done that with patients, friends, and family is I let them know that they're the expert in their body. A lot of time there's a power dynamic, right, in the room that's happening, where I don't want to bring something up. I've even had patients say, I don't want to sound dumb. I don't want to sound foolish. And they're almost intimidated by you. So a nice way that I've framed a way to build trust is there's nothing that's dumb. If anything, you are the expert in being you. You are the expert in your body. I know science, I know medicine, but I'm still getting to know you. I'm still getting to know how your body reacts to certain treatments we try or certain recommendations we do. So how about you share your expertise with me? And sometimes just even framing it that way is a little bit empowering. They're like, they look at me and they're like, okay, I guess I am an expert in being myself. And I think those are great ways to like validate, just, keep giving that validation and the affirmation of them understanding their bodies. It'll also make them be more attentive. Because I've had patients say, you know what, once you said that to me, I started, taking note of how I respond to certain things. And I really got curious about how I respond to certain treatments, how I'm feeling in a certain day, and actually really put some intimate care into hearing my body and listening to my body. So that's one of the ways that I say it. I'm like, you're an expert in your body. I might be a little bit of an expert on the medicine side, but let's share our expertise and see where we meet in the middle to make sure that I'm addressing your needs. And then I always leave it, when I think about trust, I always reinforce what my goal is. I say, my goal as your doctor is to make sure that I keep you alive and functional so you can live the best life that you can for your family and for yourself. And sometimes we almost forget about that goal. We forget about what that means. My goal is to make sure that I'm giving you the best fighting chance to live a full life. And how that looks like for you, you tell me. You tell me what's most important to you. You tell me what you want to make sure you live for, what's important for you to be able to be alive for with your family. And then when I talk about your hypertension, when I talk about your needing for other vaccinations like your Tdap or you getting your colon screening, I bring it back to that whole point. Like, wouldn't you be upset at this moment if a year from now, you end up in the hospital because of symptoms and we find out it was colon cancer and we had a chance to intervene, because now this stops your ability to see your grandkids, stops your ability to go to work, stops your ability to live that full life you told me you wanted. If that's the case, let me share my expertise with you to tell you what science has taught us that screening at this time, getting this information is going to help us get to your goal. And a lot of times it's framing it so they really feel like we're in partnership with them, so we can continue to build that trusting relationship together.
I wanted to ask Mark, I keep thinking of ways that public health could help sort of get everybody vaccinated and then steer people back to primary care. And I'm thinking of, as you drive through and get your shots, you could get an age appropriate, list of things that you need to check back in with your primary care doctor with, or screenings that you should get, or some patient education, or there's just so many ways that public health and primary care could work together. But what about health plans? I'm just curious, Mark, if you guys have thought about what role health plans could play in, you're clearly collecting this data and seeing that people aren't going in.
Yeah. So that's a great question, because there's a vital role that we could play. We could play a vital role in collaboration with our provider partners in this, making sure we have access to data and access to real-time information in many cases. And what our plans are doing right now is actually reaching out to our members, because they know what members have missed their screenings. They know what members have missed their wellness shots. They have specific, they know of their members that have chronic conditions, whether it be diabetes, heart failure, COPD. So what our plans are doing now is actually reaching out, identifying who these members are, identifying the vulnerability of them based on what has happened over the past year, and reaching out to them proactively to try to get them engaged in their healthcare and engage with their providers. So I think there's a very proactive role that we could play, and we are playing, in terms of how do we leverage the data that we have and use that data to help members not only become educated on the importance of their screenings, because and the importance of their screenings and the timing of their screenings and wellness visits, but also coordinating their care as well. As you know, many of our plans are heavily invested in their communities. We're Blue-based, we're community-based, Blue Cross and Blue Shield. And a lot of our plans are developing what we call determinants of health, transportation, vehicles. We look at food options, transportation options, and try to reduce barriers into accessing care. So all of this plays a vital role, not only the data, but the partnerships that we have, being locally community-based with the community, and making sure that all of our members across socioeconomic status, race status, are getting the care that they need and deserve, and breaking down access and barriers. So that's what our Blue plans are doing right now in terms of helping through this pandemic. It's playing out in the vaccination space right now, working closely with our plans and the administration to making sure that the most vulnerable populations through the Vaccine Connector program get vaccinated. And it's also playing out in terms of the next wave, in terms of what we've seen with our data right now, with lower cancer screenings, lower wellness visits, and what the downstream impact of that could be in the future.
Well, I'm very happy to hear that, Mark, because that was some of the what we were hoping for, that all of this does not just fall in the laps of primary care providers to get things on track, because it's going to take everyone. It's an all hands approach. And though I cannot speak to this with any data, because most of it is just anecdotal information and what we have seen in the news, that the primary care community has really been hit hard by this, and there was a shortage of primary care providers in many areas before the pandemic, and we've gotten information that a lot of small groups or solo practices have closed permanently. There's also the issue of community health centers that were struggling before the pandemic, and that really serve the medically underserved. And those primary care facilities are, some have closed and some are struggling, and not to mention the shift in resources to address COVID-related illness away from other chronic conditions. So I'm very happy to hear that at least one insurance provider is taking a very proactive approach. And Blue Cross Blue Shield is not my provider, but I've gotten similar outreach from my provider about cancer screening and preventive care. So,
Great. We have time for just one more question from the audience. And what I'm going to do is just ask any of you to comment on telehealth, because telehealth, telemedicine has been a sort of a theme throughout the questions in the audience. And specifically, what about seniors or people who just don't believe in that telehealth is a reasonable way to engage with your physician? Is telehealth the solution, or is it part of the problem, or where are we with telehealth?
Mhm.
I think it can be an augmentation to what we have. I don't know if I would say it's the solution because it can actually worsen health disparities, especially when we talk about access in different groups. I do think we have to think of it from multiple standpoints. So initially, I know even in my practice last year, we actually didn't even have telehealth up and running. So we had to quickly get it up and running. But the also concern that was easily coming up was reimbursement, right? So we were fortunate where reimbursement was matched. So then people got really excited about it. But I'll even say within my practice, you needed an email to be able to get your visit and
Yes.
think about that older population that are like, what, excuse me, what's an email? I'm not doing that. And I had a lot of my older patients that were very reluctant for that reason. So we had to find another modification that allowed us to use the phone, but then you're also assuming that someone has a smartphone and has access to enough data so they could be able to have a video visit, right? So there's a lot of things that we're going to have to find solutions to for it to truly be an augmentation to health. One of the best ways that I was able to use it in the pandemic, especially when I couldn't go into the office every single day because we had to monitor how many physicians were in the office seeing patients, is I would do a telehealth visit so they could see me, we could have discussions, and then I would partner and say, you're going to see me in the office in a week or two or whatever that was necessary. And then in that interim, here are your instructions. Get these labs, get this test done, and then we go through with that. So augmentation in that it can really help so you can still have that dialogue that's so necessary, but you don't have to prolong care and getting testing and getting things done. I also thoroughly enjoyed being able to see patients in their environment and actually getting to see them at home. And then it prompted other questions about social determinants of health that they may have not told me and they may not have suggested. So an example would be, I was on a telehealth visit and then I saw so many people at home. I said, oh my gosh, your whole family's home and it's during the week. And then the patient ended up saying, oh yeah, because my wife also lost her job as well. She typically would have been working. So in my mind, that also became a cue of, ooh, so I have to think about this when I have him come for visits, what his co-pays look like and all these other things that may not have been shared in the office because he may have just left it at home and not discussed it. So there's a lot of opportunity, but it's not the golden nugget. There's a lot of work that has to go into implementation, making sure we're addressing equity gaps, to make sure there's access to it and making sure we tally this up with in-person visits. So I think the sequence and the strategy is very important.
Right.
And on that note, it's 2:00 and I want to thank everyone for joining us and for sharing your insights. I think we've had a great panel discussion today, a great conversation. The slides and the recording and the additional resources are available on the PCC website. The recording to the webinar will be posted within 24 hours. Thank you all for joining.
Thank you all. Bye-bye.
Thank you.